problems. Kalispera again. But I hope you have the picture, the full slide now of Weissmies and Lagenhorn from the Nadelhorn in Switzerland. And I'm going to be speaking about submacular hemorrhage in wet AMD. So subretinal hemorrhage occurs in different places, but it always damages the eye. And if it's under the fovea, then that can lead to severe loss of vision. Firstly, as the blood clot contracts, it pulls the end of the photoreceptors off the cell body, leaving a blind spot. Secondly, as the hemoglobin breaks down, it's converted to hemosiderin, and that means that you get iron toxicity in the same way as you do with an intraocular foreign body, and that damages any of the photoreceptors that are left from there. And finally, of course, this blood creates a barrier between the choroid and RPE and the photoreceptors, and so that destroys the metabolic support that the photoreceptors require. So submacular hemorrhage is very bad news for macular function. Sylvia Bopp produced quite a useful classification of submacular hemorrhages. Grade 1 hemorrhage is just a little fleck in the retina there, which is what you see in a RAP, retinal angiomatous proliferation. Then you can get a circular hemorrhage like this that occurs just at the edge of a classical membrane. And you can get a very small, thin hemorrhage, less than 2 disc areas. Now, these three really don't cause too much trouble. It's when you get bigger, thicker hemorrhages like this, a grade 4 hemorrhage, more than 2 disc areas, more than 500 microns thick, or what you call a massive hemorrhage, one that extends out to beyond the arcades you can see there. And these are the ones that will not get better. These are the ones that will do a lot of damage to the macula and to the photoreceptors. Fortunately, they're relatively uncommon. This is looking at Sylvia Bopp's paper, looking at over 500 patients with AMD, and only about 6% of them had the grade 4 or grade 5 hemorrhages that are likely to require treatment. In Scotland, we found that the incidence of this was about 5.5 per million per year. The majority were female, they were fairly elderly, and this is important. Most of the people presenting with a hemorrhage like this didn't know they had exudative AMD. They weren't already on treatment. So this may be the presenting feature of untreated exudative neovascular AMD. So if you have somebody who's got a big hemorrhage like this, what are the treatment options? Well, observation would be one. And the reason why observation is a valid option is that there's no randomized controlled trial evidence to prove that any intervention is better than observation. We don't have any RCTs yet. However, we do have the submacular surgery trial from the 1990s, and that showed that the untreated prognosis of a large hemorrhage like this is very poor. So in practice, I don't think observation is a good option. The alternatives are just to treat with anti-VEGF alone, to use an intravitreal gas bubble with TPA to displace the hemorrhage, or to do a vitrectomy and inject subretinal TPA and a gas bubble and displace the hemorrhage even more. So anti-VEGF alone can work. There are a number of publications that suggest quite a good prognosis with simply injections of ranibizumab or bevacizumab or aflibercept. The CAT study in the States showed no difference in the visual outcome between those lesions that were predominantly hemorrhagic or those lesions that had no hemorrhage. But, and this is a very big but, the mean pre-treatment visual acuity in these predominantly hemorrhagic lesions was 56 letters, and the mean lesion size was only 4.5 disc areas, about 9 millimeters squared. So these were probably quite small hemorrhages because the vision was good and they weren't that big. And so in a small hemorrhage with reasonably good vision, then anti-VEGF alone can work quite well. But what about bigger hemorrhages? If it's a big hemorrhage and the vision is poor, less than 25 letters or 696, then in the UK, that would mean that they are ineligible for anti-VEGF treatment. If there's blood under the fovea, more than 10 square millimeters of area, that's roughly equivalent to over 5 disc areas, and more than 500 microns thickness, then these are probably not going to do well with anti-VEGF alone. So your options for these are either an intravitreal gas bubble with TPA or a vitrectomy and subretinal TPA and gas. So the technique for intravitreal TPA is that you put in 0.3 ml of C3F8, pure 100% C3F8, and 50 micrograms of TPA. So very similar to a pneumatic retinopexy, except you're also giving TPA. And that means that you're putting a bit of a volume into that eye. And so it's sensible to do an AC paracentesis before the injection and again after the injection. You then mobilize the patient. Don't posture them straight away. It's important to mobilize them to make that bubble and the TPA mix around inside the eye. And then they have to do a strict face-down posture. They have to be bent right over with their nose pointing at the floor and looking down between their heels. And they've got to stay like that for at least overnight. And then you review them the next day to see if the hemorrhage has been adequately displaced. And if it has, then you can go ahead and give the intravitreal ranibizumab or bevacizumab. If it hasn't, you may posture them for longer before giving the intravitreal anti-VEGF. And using that technique, one of the largest case series, so reasonably indicative results, 64% had gained 2 lines at 12 months, 10 or more letters, and about half of them, just over half of them, were 360 or better. So it does work. Vitrectomy with subretinal TPA and gas is a much more invasive procedure. You remove all of the vitreous, and then you inject with a subretinal cannula 50 micrograms of TPA plus the anti-VEGF, ranibizumab or bevacizumab, and then fill the eye with a 20% SF6 mixture. You lie the patient flat on their back for 2 to 4 hours, just to allow the TPA to lyse the clot under the retina, and then you sit the patient up and lean them forward. They don't have to have quite such strict posturing here. So long as they're sitting up and leaning forward a bit, that will be enough to displace the blood. And with that, a rather better improvement, 77% regaining 2 lines at 12 months, not quite so many gaining 360 or better. That's probably because these are bigger hemorrhages to start with. Note that it is important to use ranibizumab or bevacizumab. And the reason for that is that TPA, tissue plasminogen activator, is a proteolytic enzyme, and it will inactivate aflibercept. So don't use aflibercept, use ranibizumab or bevacizumab, at least for the first injection. Now, it's very difficult to compare different techniques because there are something like 50 different case series or case reports of using some variant of these techniques to displace submacular hemorrhage. And they have different criteria for entry into the study, different pathologies, the interventions studied vary enormously. Many of the case series describe a unique particular twist to the technique, and the outcomes that are used to measure the outcome are also rather variable. Some outcomes look at an anatomical outcome, looking at just the displacement of the hemorrhage. Others look at a visual functional outcome, looking either at the final vision or the change in vision. And of course, as with all of these kind of studies, the reporting of complications is incomplete and usually inconsistent. So what outcomes might we consider to be important? Obviously, displacement of the hemorrhage. If we can't move the hemorrhage, then we really haven't achieved anything. The problem is that even if you do displace the hemorrhage, the vision may not improve. These patients may have extensive atrophy. They may have combined dry and neovascular macular degeneration. Vision change, well, we want to know that we've improved the vision, but if somebody's only hand motions to start with, then a 10-letter gain will still leave them with very poor vision. I think the best vision outcome is probably to know what their latest vision is, and that can be either the mean visual acuity, or I think better still, a kind of threshold visual acuity. What proportion are 660 or better? That's to say they've regained navigational vision in that eye. What proportion are 618 or better that have regained reading vision in the affected eye? And there are a number of different factors that will affect the final visual outcome. And these are the factors that we identified from our own study in Glasgow, the most important of which was the area of the hemorrhage, the size of the hemorrhage. If it's a relatively small hemorrhage, the mean final vision is better than 660. If it's a big hemorrhage, it's only just a little better than counting fingers. Duration is important. If the history of vision loss is less than 5 days, they do quite well. If it's over a week, they do less well. And if it's over 2 weeks, it's probably not worth treating at all. The presenting vision makes a difference as well. If they can see 160 or better, then their final visual acuity is likely to be 660 or better. If they're down to hand motions or light perception, then they're still going to have poor vision even after you clear the hemorrhage. I said at the start that on the last slide that the most important factor is the size of the hemorrhage. And you can calculate a ROC curve, receiver operating characteristics curve, that shows that the best predictor of getting 660 or better vision is the size of the hemorrhage. And if the area of the hemorrhage is 32 millimeters or greater, then they are very unlikely, only a 9% chance of getting 660 or better vision. And you can see it's quite a nice sharp ROC curve that says that that's a useful cutoff point when you're explaining the prognosis to patients. Big hemorrhage has a worse prognosis. Now, duration was the other thing that is important. And we can't change the size of the hemorrhage. We can't change the presenting visual acuity, but we can, to some extent, affect the duration. And this is a very small series, only 8 eyes, but the point is that they were all treated within 3 days of losing vision. They had intravitreal TPA, a bubble of C3F8 plus TPA, and then ranibizumab. And look at the improvement in vision. They went from a mean preoperative vision of only just better than counting fingers to a postoperative vision of nearly 618. So that's a huge improvement. 7 out of 8 eyes were better than 660. Now, this is a small series and small hemorrhages, but it does suggest that if you can treat these eyes very promptly, they're going to do better than if they're left for a week before you displace the hemorrhage. And that makes sense. It's a sensible and biologically plausible thing. So it is important for us when we're considering submacular hemorrhages, really think about how we can minimize the delay in treatment, minimize the interval between the patient losing vision and getting treatment. And that means maximizing awareness. We need all the ophthalmologists in the area to know what to do when they see a patient who's got a big sudden onset submacular hemorrhage, with a clear pathway from the macular degeneration clinic to the vitreoretinal clinic. And in Glasgow, we have a policy that when the patient is seen in a peripheral hospital, we see them in our clinic the following day, and we get them into theatre the day after that. And that's the best way to get good results. Now, some people are concerned about the presence of a pigment epithelial detachment and sub-RPE bleeding. And all of these patients will probably have a somewhat mixed picture of some subretinal blood and some subpigment epithelial bleeding. And the worry is that the sub-RPE blood may not be displaced as easily as the subretinal blood. In practice, although theoretically that might be an issue, in practice it is not an issue. We know from Yorston D and others' work that sub-RPE blood is displaced just as effectively as subretinal blood, and there's no difference in the functional outcome between eyes that have predominantly sub-RPE hemorrhage and eyes that have predominantly subretinal hemorrhage. Another concern about sub-RPE bleeding is whether if you displace that blood, you get an RPE rip. And that certainly is a risk. About 10% of these eyes will develop an RPE rip. However, that is also true if you treat with anti-VEGF alone. So displacing the hemorrhage doesn't appear to significantly increase the risk of an RPE rib. So what everybody wants to know is what procedure is better. What should I do? Should I do the subretinal TPA, do a vitrectomy and inject the drug under the retina? Or should I do intravitreal TPA, in which I just inject a bubble of gas and the TPA into the vitreous itself? One operation is obviously rather more complex and invasive than the other. Is there any difference in the effectiveness? Well, Just Hillenkamp and others showed that the subretinal TPA displaces the hemorrhage much more effectively than intravitreal TPA. This wasn't a randomized trial, but they looked at 18 eyes that were given intravitreal TPA and 29 eyes that had vitrectomy and subretinal TPA, and they showed a big difference there. So clearly much more effective. Jan van Meurs and his group in the Netherlands looked at subretinal TPA with vitrectomy, and they randomized 12 patients to intravitreal TPA and gas, and 12 eyes to vitrectomy and subretinal TPA and gas, and they found absolutely no difference. So it's very confusing. We don't know which is better. And I think it's important to put that in perspective. We all want to know what's the best operation, but actually the type of operation probably doesn't matter very much. The things that dictate the outcome are the size of the hemorrhage, the thickness and the area, the duration of the hemorrhage, the initial visual acuity, perhaps to some extent the underlying pathology. The type of procedure doesn't matter that much. So perhaps if you're feeling a little bit mystified and wondering, where on earth do I go from here now that I've got myself into this difficult situation, there are a few simple guidelines that will perhaps clear some of the confusion. I think the first thing that all of us need to do is ensure that there is a clear referral pathway. So if a patient presents with a big hemorrhage, one of Sylvia Bopp's type 4 or type 5 hemorrhages, then there should be a clear referral pathway that can get them treated promptly. Because speed of treatment is probably more important than type of treatment. If it's a small hemorrhage with reasonably good visual acuity, then anti-VEGF alone is perfectly reasonable. If it's a big hemorrhage over 30 square millimeters, then we've got to be clear with the patient that they're probably not going to get good vision afterwards. It may still be worth doing the surgery because they'll get no vision if we don't do it, but we need to be clear that they're very unlikely to regain reading vision in that eye. We should be aiming to treat these patients promptly as soon as we possibly can, because a shorter duration means a better outcome. There's no point in doing the surgery more than 2 weeks after the bleed, because they're not going to benefit. Now, the treatment is gas, TPA, and anti-VEGF, and how you give that varies. Some evidence that doing a vitrectomy and putting the subretinal TPA under the retina is more effective, but it's not really conclusive evidence. And bearing in mind that duration is so important, if you can give the intravitreal gas and TPA immediately, this may in fact be better than doing a vitrectomy and subretinal TPA a day or two later. If they can't posture well, then vitrectomy and subretinal TPA is probably better because the posturing can be less strict. With this elderly population, posturing may be a problem. If you're going to do these treatments, then I would ask that you do try to specify what your entry criteria are, think about the duration and the area, and report the visual outcomes as a percentage of regaining 660, as well as the percentage regaining 10 or more letters. And that way you can contribute to the body of knowledge about this. Ultimately, we need a proper clinical trial, and one is about or was about to start before the coronavirus hit, the TIGER study, which has been funded by Bayer and Euretina, and that's going to look at anti-VEGF alone versus vitrectomy and subretinal TPA. I've already mentioned standardized reporting. There is a data set available, and if anybody wants that, then I can send it to them. And if anybody is interested in reading more about this, there is an excellent review article by Tim Jackson and colleagues. It's a few years old, but it hasn't changed very much since then. Thank you very much. There are some questions, but I'm not sure how to show those. So I'm going to stop sharing this screen, and I hope that we will go back to the StreamYard. Okay.
Okay. So I think we have your question, your first question on the screen, which is the following patient require immediate referral for treatment. You want to make a quick comment? And I have asked Paris also to join us and continue. Πάρη είναι η πρώτη ερώτηση.
Do you want to do the poll first, and then I'll comment on the answer?
I think it's better David reads the question and we get the answer, and then we can comment on this afterwards.
So, 75-year-old man with a vision of counting fingers in the better eye for 2 to 3 weeks, large subfoveal hemorrhage, approximately 10 disc areas. Does that require urgent referral or immediate referral or not? Second is a 75-year-old man with a vision of 50 ETDRS letters, 3-day history of vision loss, moderate-sized hemorrhage, about 4 disc areas. 75-year-old man with 10 letters, 5-day history, quite a large hemorrhage, 6 disc areas. The last one, 75-year-old man with a vision of hand motions, 3-day history. However, he had known exudative AMD. He was on treatment, and best previous vision was about 20 letters. And he's got good vision in the other eye, and it's a big hemorrhage. So, do we take the poll now? Okay, so which of those would you send for urgent treatment? Okay, that's good. Let me go through those. Number 1 is not worth treating, and nobody thought it was, because he's got 2 to 3 weeks history, and he's not going to get better. Number 2 has got quite good vision, and it's a small hemorrhage, and I would be inclined just to treat that with anti-VEGF rather than referring for surgery. Number 3 is the absolute classic case. That's the one you want to get. You want to get up very quickly and treat as soon as possible with either pneumatic displacement or a vitrectomy and subretinal TPA. Number 4, the thing is, this patient has got a pretty poor prognosis because the vision was very poor beforehand. He's got good vision in the other eye, and I would probably not rush to treat that one. You could treat it, but I wouldn't be in a hurry to. So that's the first question. The second question.
David, before we proceed to the next one, because you very cleverly put the last option in a patient who has good vision in the other eye, what if we are talking about the only eye? And have you ever come across a case that was maybe 2 or 3 weeks old, the hemorrhage, and it was the only eye? So would you intervene in such cases?
If we take this one, number 4, if the vision was very bad in the other eye, if there was hand motions in the other eye as well, then that could be really important to him, and I would treat it. And that's why I specified 75 letters in the other eye. Under those circumstances, I probably wouldn't treat. If it was an only eye, I would. Now, your other question was, what about an only eye if it's 2 weeks? I still wouldn't treat then, because in my experience, it's hopeless once they've been there for 2 weeks. I think you've had the blood clot has contracted, ripped off the photoreceptors, you've got a lot of RPE atrophy under there. You're really just putting them through an operation that isn't going to help them at all.
Right. And the second question is that in large hemorrhages, massive hemorrhages. If it is again the only eye, and knowing that those cases carry very bad prognosis, would you be more aggressive and start injecting air under the retina, try to display to make more space, or maybe drain, intraoperative drain, and at that time? Do you think that this makes sense, or you would just do the normal?
I would just do normal. I don't see the rationale for putting air under the retina. What you want is the air outside the retina, in front of the retina, so that there's a big difference in the specific gravity of what's in front of the retina and what's behind the retina. And it's that difference that displaces the blood. And if you put air under the retina, you're reducing that difference. So I've never understood the rationale for it. It doesn't seem to make sense to me at all. And it places very well with the TPA under the retina anyway. So displacement isn't the problem. It's the damage to the retina caused by AMD that limits the final visual acuity.
Okay, that's fair enough.
Okay, should we move into your second question? If you... Excellent.
Yeah. Again, only one of these is true. Sub-RP hemorrhage doesn't require treatment. There's strong evidence that vitrectomy and subretinal TPA is better than intravitreal TPA and gas. In vitrectomy and subretinal TPA, patients must posture strictly face down for 7 days. The last question of aflibercept is inactivated by TPA. And which of those is correct? You see the poll? Waiting. Here we are. Good, excellent. And the correct answer is number 4. Aflibercept is inactivated by TPA. Jost Hillenkamp and some of his colleagues mixed up TPA with aflibercept and ranibizumab and bevacizumab and looked at the biological activity, and they found that bevacizumab and ranibizumab were unaffected by TPA, but aflibercept is inactivated by TPA. So it doesn't make any difference in subsequent injections, but in the first injection, when there's still TPA in the eye, then best to use aflibercept. The other one, sub-RPE hemorrhage, behaves in exactly the same way as subretinal hemorrhage. There's no difference. So if you're going to treat subretinal hemorrhage, you should also treat the sub-RPE hemorrhage. And there's no really strong evidence that vitrectomy or intravitreal is better. Both work, and it's probably more important to give them quickly than it is to give one or the other. And following vitrectomy, you don't need strict face-down posture, certainly not for 7 days. You need face-forward posture like this, or overnight will do, and that's usually enough to displace it. So if somebody can't posture well, vitrectomy and subretinal TPA is better than intravitreal gas bubble. And the reason is that with an intravitreal gas bubble, the gas bubble will enlarge to about 30% to 50% of the eye. With a vitrectomy and gas bubble, you're filling 80% of the eye. So the posture is less critical. Just leaning forward will do it. That's it, I think.
And Paris, do you want to quickly add anything before the break?
No, that's, I think that we're behind time. So thank you very much, David. It was great. Very
I'm sorry about the technical issue.
Thank you.